Thank you very much for inviting me to present the data on the results of treatment or effect of treatment in the Italian population that participated in the Italian CIDP database. I would like to thank the organizer, the Dutch Congress, for inviting me, and LFB for supporting my presentation. First of all, I would like to present my conflict of interest. As you can see, I have some conflict of interest, mostly by company that working on immunoglobulin, but this will not influence my presentation at all. So we are talking about a chronic inflammatory demyelinating polyradicular neuropathy. That is an old slide, which I take from a review by Professor Dick. And you see, it is a rare disease. We are talking about a disease whose prevalence is less than 10 per 100,000 people. It is a chronic progressive, stepwise or recurrent symmetrical proximal and distal weakness with sensory dysfunction of two or more extremities. It's characterized by loss of reflex and is typically the myelinating neuropathy. The most important things about this neuropathy, that is a treatable neuropathy with more than almost very few patients who remain disabled, even though during the course of the disease, at least 50% of them get some disability, major or minor disability. So the fact that it's treatable and the fact that there are some expensive treatment for this led to the use of a number of diagnostic criteria that for the diagnosis. The most frequently used in most clinical trials are the criteria that has been published by the FNS, PNS in 2010, and where for the first things is introduced a very interesting issue for the first things. So beside the clinical typical CIDP, which is chronic progressive stepwise or recurrent symmetric proximal and distal neuropathy, so the typical CIDP, which is clinically characterized by loss of sensation, loss of strength, and absent reflex, they introduce the concept of atypical CIDP, or CIDP variant, where we have forms which are typically purely motor, purely sensory, or distal, or asymmetric, or focal. The point is that despite this introduction of this new diagnostic criteria, there are no strict diagnostic criteria for this. And this is not just a matter of name, because as we'll see during the presentation, some of these presentation are a different response to therapy compared to typical CIDP. And that is explained the lack of a definite criteria why the proportion of patients to respond to some of these forms, particularly distal CIDP or Lewis-Sumner syndromes, varies considerably from studies to study. To answer some of these questions, and to answer some of other questions on CIDP, in 2013 we set up a database which include almost 30 Italian centers that you can see here, and that was supported by a grant from Regione Lombardia. And during this grant we collect over 636 patients according to this patient. So this was a very useful tool to review the clinical data, the diagnosis, and the response to treatment, and of course I will focus on response to treatment. That is a schema of the patient which has been enrolled. We enrolled 630, and we will mainly focus on patient who has a typical diagnosis, excluding the one who has side effect. And we will firstly focus on the patient who has a diagnosis according to the FNS-PNS criteria. I know that this criteria has been recently changed, but all the study has been set up on this criteria. The first things I would like to show what is a proportion of patients who has a typical, as I mentioned to you, that there is a variable proportion. The good things about this study that we set up a set of diagnostic criteria, which we publish on Journal Neurology, Neurosurgery, and Psychiatry, that we apply to the whole population. As you can see, we have about 80% of patients who has a typical CIDP, whereas 20% of them has an atypical presentation. And the other things, however, which was very interesting to see is in the next slide, that this is not a stable condition, because we see that at the beginning, at the onset of the disease, almost 40%, according to the story, because we took the story of the patient, we review all the data, examination, 40% could be classified as a typical CIDP, whereas at the time of enrollment, which it was an average about 8 years after starting of the disease, just 20% of them had a typical atypical CIDP. And that is important because even for the new diagnostic criteria, when we talk about, pure motor and sensory, that, probably that is a dynamical process, and some of the disease, start in a way and change during the course of the disease. And it's important to know that some of this form may evolve into, more typical form. So, what about the treatment? Treatment for CIDP, we know from a number of randomized controlled trials, as well as from some Cochrane review, that there are 3 treatments which are available for and which are effective, which has been shown to be effective on CIDP, which is corticosteroid, plasma exchange, intravenous immunoglobulin. And if we look at the guideline, that the FNS PNS guideline, say, beside the fact that IVIG or corticosteroid are the mostly used and the one who show most frequently a response, I think that the definition or the choice of treatment should be mostly guided by the presence of contraindication to this treatment. One of the points of most of these randomized controlled trial is the fact that most of the patients which is included in the trial probably are a part of the patient with CIDP, because they exclude patients with diabetes, with other disease, with other contraindication. But these are kind of frequent. When we talk about contraindication, one thing is a trial and one thing is in real life. For instance, we saw that in our series, so about the 390, we reviewed the data about this patient, you say that say just 25% have no comorbidity, 26 have comorbidity, which were not affecting the choice of the disease, whereas about 50% have some contraindication, which are not some contraindication. Some contraindication against some, against some kind of treatment. Arterial hypertension, of course, may be a problem for patient who has taken steroids, as well as diabetes. Cardiovascular disease can be a problem both for IVIG, immunoglobulin, and steroids, and other disease, thrombose can be a problem for steroids. So I think that is a major point. Let's move to response to therapy. What happened in the Italian population? These are the data on over 500 patients. And the very good news is that 84% of patients who received some treatment, so not taking account the patients who were so mild and who were not treated, 84% respond to treatment, which correspond to 74% of the whole population. So the vast majority of patients respond to treatment. And we also see that, confirming some data, even in this a real-life population, that IVIG were more effective than the other therapy. You see here the patient who in blue have been treated, the number will improve, stable or worse, and you see that patients who had IVIG among this series, 74% of the patients respond to IVIG, towards 54% of patients who respond to steroids, and 58% of the patients who respond to plasma exchange. So there is a, IVIG seems to be indeed more effective. That is, of course, a retrospective studies, but I think it's important to the large number of studies. And of course, the criteria of improvement, which was at least 2 points on the MRSC sum score or 1 point in INCAT, were applied to all the population. But things were not the same for all disease. For instance, we compare the proportion of patients who respond to typical CIDP and with the patient who respond to atypical form of CIDP. There is some difference between the two. But if we split the data according to the type of atypical, we see that there are some 2 forms that seems to be less responsive than a patient who has typical CIDP compared to, for instance, patient with distal CIDP respond significantly, almost significantly lower than patient with typical CIDP, and the same occur for patient who has a multifocal or Lewis-Sumner syndrome. And that is related to the fact that both conditions, both distal CIDP and Lewis-Sumner syndrome, respond well less well than typical CIDP to IVIG. So it's not that they do not respond, but we may expect that this patient respond less frequently. And that is an important issue, both from the therapeutic point of view, but also from a pathogenetic point of view, that make us think that there might be some difference between this condition and the typical presentation of CIDP. Another issue, which is, I think, is very important, and I think it's been taken into account in the new criteria, is that in this population, there is about 14–15% of patients who do not fulfill the previous criteria of the PNS for CIDP, some of them typical or atypical. But if we look at these patients, that I think it is interesting, because these are patients in whom we could not make a diagnosis because we do not have electroconduction studies, abnormalities of motor nerve. But if you look at all these patients respond to their therapy similarly to patients who has a typical CIDP. They have the same proportion of patients who have increased CSF protein, and the similar proportion of patients who has a relapsing course, which is kind of characterized. And if we put together this data, we see that almost 73% had at least 2 supportive criteria for the diagnosis of CIDP, even if they could not achieve this diagnosis. And the other important thing is also the treatment. And if we look at the patient with clinical CIDP, those who were treated compared to the patient who has the typical form of CIDP, you see that the proportion of patients who respond to IVIG is identical, 73% in this series, 74%, and similar for steroids, and probably a little bit less than plasma changes. So it looks like that this patient that we were not allowed to make a diagnosis in according to criteria actually respond to therapy. And that I think is an important issue which has been included in the new AIN PNS criteria, where we finally, even for the diagnosis of typical CIDP, we can make a diagnosis even if you do not have motor conduction abnormality, as far as you have other sensory abnormality or a jerky response to treatment and other supportive criteria for the diagnosis. So I try to make an overview of the treatment, of what we learn from our series of patients. Thank you very much again for the invitation. And of course, I would like to thank all the people who of the Italian CIDP database who contributed to the work and who the collection of all this data. And of course, I would like also to thank again all my collaborators, which are here in blue, and the Deutsche Congress for inviting me, and LFB for supporting my participation at this Congress. And I'll be glad to answer to all of your questions. And thank you again.